Hello, and welcome to Navigating Health Insurance with Type 1 Diabetes, hosted by the Mary and Dick Allen Diabetes Center at Hoag Hospital. We're just in time to kick off open enrollment season, and our goal today is to help empower you to choose the best available coverage and get the most out of whatever option you choose for this upcoming year. I'm Samantha Markovitz, National Board Certified Health and Wellness Coach and Supervisor of Health and Wellness Initiatives at the Mary and Dick Allen Diabetes Center. I'm here with our Program Director and Endocrinologist, Dr. David On.
Hello. So as Samantha introduced me, I'm an adult endocrinologist. I love helping people with type 1 diabetes, and it's something I'm very passionate about. And we're both very passionate about at the Mary and Dick Allen Diabetes Center. And I'll be trying to add a little bit of the provider side perspective when we discuss this really complex topic. It's confusing for us. It's confusing for patients. It's confusing for the office staff. And so hopefully we can provide a little bit of clarity and, get a little bit of different perspectives throughout the event.
Great, thank you, Dr. On. Next slide, please. We're very glad that you've chosen to join us for this presentation, and we hope you'll find it educational and empowering as you navigate health insurance, either as a person living with type 1 diabetes or as a person who cares about someone living with diabetes. Of course, coverage can vary greatly from policy to policy, and changes may be made frequently by your insurance company. So we do recommend going directly to the source of your coverage with any questions about your specific policy and ensure that you consult with your diabetes team regarding your prescribed diabetes regimen. This is also a great time for us to note that we're mostly going to be focusing on commercial insurance for adults living with type 1 diabetes. If you have additional questions about other types of insurance or demographic groups, we'll certainly do our best to point you in the direction of a resource that may more thoroughly address your questions and concerns. This presentation will also be made available on the Hoag Health YouTube channel, so you can take a second look or listen later on if you want to review a topic or share with someone who wasn't able to join for the live presentation. Next slide, please. As everyone here knows, there's so much to cover on this topic. We're going to do our best to talk about the most pressing issues, and we're aware that we can't possibly include every detail, but we will just try to get as many of those questions answered throughout the presentation as appropriate. And we'll circle back to any unanswered audience questions and new questions in the Q&A at the end of the presentation. Next slide, please. All right, we're going to be starting at the very beginning here. We're just going to try to understand the basics about insurance with type 1 diabetes. Next slide. So there are many, many reasons to maintain comprehensive health coverage, whether or not you have diabetes. However, the many costs associated with diabetes, like the high cost of insulin, all of the specialist visits, preventing complications, screenings, and all of the treatment that's involved in living with diabetes, are just a few things that are typically covered. Insurance, of course, won't take on the full financial burden, but it can help to significantly defray your out-of-pocket costs as the patient. The system itself still has a lot of things that need to be worked on, but it's worth highlighting some of the provisions of the Affordable Care Act that positively impacted the way that people living with diabetes interact with health insurance. They have some imperfections still now, but prior to this becoming the law, people living with diabetes and other pre-existing conditions had far fewer options or support as far as health insurance and diabetes costs were concerned. So here are a few things to note about your insurance policy as a result of the ACA, if your plan is ACA compliant. The law now allows for young adults to stay on a parent's plan until age 26, maybe with a few exceptions. So if you're approaching the age of 26, definitely encourage you to start thinking about your options in advance. You definitely want to think about it beforehand. Some people choose to kind of put it off because they're afraid of having to figure it out, or they're not sure what their options are. But if you start asking those questions earlier on, you'll learn more. You'll be able to make some phone calls, chat with some people who can answer those questions, and hopefully determine your best option with less stress. So that way, when your birthday comes around, you'll know exactly what you're going to do. There are certain things that insurance companies must now agree to cover. For example, they are not allowed to exclude insulin coverage for people with diabetes. There's no longer a lifetime limit as far as how many dollars can be spent on coverage for the individual with diabetes. And people with diabetes cannot be denied coverage under a health insurance policy or be charged more than others without diabetes for that same coverage. In addition, Medi-Cal, which is California's Medicaid program, now has a wider reach. So folks who do not have coverage but are also not eligible for Medi-Cal may qualify to receive premium subsidy and cost sharing assistance to help cover their healthcare costs if they purchase through the marketplace. The individual mandate, which is also known as a fine for not having insurance that meets the ACA standard, has been struck down on a federal level. However, we're located here in California, and that individual mandate is still in place on the state level here. So that means that if you live in California and you do not have health coverage, you will pay a penalty for choosing to not maintain that coverage. So if you're going to be paying money for healthcare coverage or a penalty, you might as well put those dollars towards the health insurance, which can help cover the costs of living with type 1 diabetes. So our next question is, how can you get coverage and stay covered? Next slide. Open enrollment will be based on your employer as far as when that's going to take place. It usually takes place right around this time in the fall. And if you're planning to enroll in a plan through Covered California, which is the insurance marketplace here in the state of California, open enrollment will take place beginning this coming Monday, November 1st, through January 31st, 2023. Employment-based health insurance tends to be the norm here in the US. And typically, if an employee works at least an average of 30 hours a week or 130 hours per month, they're considered full-time in the eyes of the ACA, and employers of a certain size must offer health insurance to these individuals. As I mentioned earlier, if you're under the age of 26, you could stay on a family plan with your parents or guardian. If you have a spouse or domestic partner with access to employer-provided coverage, you could potentially join them on that plan. And if you lose your job or you have a situation where your hours drop down below insurance eligibility, you'll have access to COBRA, which is a continuation of your current coverage. The plus is that in that situation, you don't have to change insurance mid-year, and you can continue paying towards that same deductible and out-of-pocket max. However, the downside is that COBRA can be very costly since you become responsible for the full premium instead of sharing the cost with your employer. This may dissuade you from pursuing COBRA coverage and push you towards an alternative. If you are not able to access health insurance from one of these other sources and you meet income eligibility requirements, you may be able to gain coverage through Medi-Cal at low or no cost to you. If you are self-employed or you do not have access to other sources of coverage but are also not eligible for Medi-Cal, you can utilize the Covered California Insurance Marketplace or exchange to search for coverage. There are both federal and state subsidies available to help make the premiums more affordable, and you may be eligible for cost sharing within your plan. If you're unsure of how to find the right plan for you through the exchange or have questions about your eligibility for certain programs, I would advise consulting with a licensed insurance broker. It doesn't cost anything to work with a broker to help you find coverage. They can help you through the process by providing quotes and information about the plans you're considering, answer questions, and continue to be a resource throughout the year if you have any issues with your carrier. Next slide, please. So, getting clear on your coverage. You need to know when you'll be electing coverage. Most of the time, this is going to be during annual open enrollment, like we were just talking about this season here. And Covered California open enrollment right now is for coverage that's active beginning January 1st. And again, that shopping period for open enrollment on the marketplace in California begins this coming Monday, November 1st. The open enrollment period will end on January 31st, 2023. Can't emphasize that too much. If you didn't write it down the first time, take a moment and write it down now. Additional qualifying life events can offer the opportunity to enroll in or make changes to health coverage. So this includes life events like losing a job or having a change in income, turning 26, entering a marriage or domestic partnership, changing your household size, being affected by natural disasters, being released from incarceration, the addition of a child to the family, domestic abuse, returning from active military service, and a number of other situations that I didn't list here. A special enrollment period lasts 60 days from the date of that qualifying life event. So if one of these things were to occur and you needed to purchase coverage, you would have a special enrollment period that would last 60 days from that QLE or qualifying life event until you would no longer be eligible to get that insurance. Whether you're making a choice between a couple of options from your employer or you're shopping for your own policy, it's important to take the time to do thorough research about the differences between the plans that are available to you. We're going to be talking more about what to look for so you compare those plans most effectively. Once you've made your selection, you got to make it your job to know what the details of that plan are so you can utilize it to its highest potential during the plan year. When you're looking to compare plans, a great place to start is to review the summary of benefits and coverage. This is a document that all insurance companies are required to provide as a result of healthcare reform. It's a standardized summary of health plan benefits and coverage, including covered benefits, cost sharing examples, coverage limitations, and exceptions.
Samantha, this is where I'll pitch in a little bit and just add a little bit of color. One of my doctor friends, he was telling in kind of conversation, he said that health insurance, if you think about it, is actually probably the third most important financial decision you make in your life, behind your house and your car. And at first I was kind of like, wow, that seems a bit dramatic. Is that really true? But if you actually think about it, and especially if you have a chronic condition like type 1 diabetes, it really is true. And if you're anything like me, you don't like going through all these different brochures and looking at all the details. But it really, really, really is so important to make sure you really map out your costs and pay attention and really try to understand all the hard terminology, because it makes a huge difference on your wallet, which plan you choose and making sure you find something that is the best fit for you. So it does get a bit complicated and dry, but it really makes a difference. And when you think of it like that, maybe that will help you make it a priority. Because I know for me, I hate looking through these documents, but they really are so important.
Absolutely. Your friend is a wise physician. It is such a huge decision. And it's something that often we want to brush off because it's boring or it's inconvenient, or maybe we're a little intimidated by all of the information. But as people living with diabetes, or if you're a person who cares about someone with diabetes, this really is something that we want to focus on, because it's going to have an influence on your health and well-being, your wallet, as you pointed out, and also your mental and emotional health throughout the year. A lot of people report being very stressed about dealing with insurance. So anything that we can do to help alleviate some of those concerns in advance, or at least become more knowledgeable and empowered in the situation, is really important. All right, let's go ahead and move on to the next slide. We're going to talk about common types of insurance plans. So the most common types of insurance plans you are going to run into are PPO and HMO plans. A PPO typically has a higher monthly premium or cost for coverage. Within that plan, you can select your own doctors from the network with no referrals required. There are also no authorizations required for basic medical coverage, but there's a possibility that some services, medications, or supplies may need prior authorization or could be excluded from the plan altogether. Within a PPO, there is coverage available for out-of-network care if needed or if you want to pursue it. It's important to remember that anything out-of-network usually has a higher out-of-pocket cost for the patient. The bottom line on PPOs is that they allow for a higher level of flexibility and patient autonomy. You get to decide where to go for care, and there isn't as much red tape to make that happen. On the other hand, HMOs usually come in at a lower monthly premium. Your care is directed by a primary care physician who issues referrals for your other providers, and those referrals must be approved by the medical group and the insurance company before you can move forward with a guarantee of coverage for that service. Folks can often save money by going with the HMO option if they can tolerate the potential restrictions and longer timelines for approval. HMOs typically have zero out of network coverage, and they have a lower level of flexibility and patient autonomy. Next slide. Other types of insurance plans that you may see offered include EPO and POS plans, which can end up being a kind of hybrid HMO PPO plan depending on the details. In an EPO, you may or may not be required to have a PCP coordinating your care. Typically, there are no referrals required, no authorizations for basic medical coverage. Some things may need prior authorization or be excluded. And there's a moderate level of flexibility and patient autonomy. So you may find that there is a higher out-of-pocket cost for you as the patient. For the POS, a PCP will be required, and referrals may also be required. You may be able to access out-of-network care depending. And again, there's no authorization required for basic medical coverage, and some services or items may need a PA or be excluded from the plan. And this type of plan also has a medium level of flexibility and autonomy. Next slide. You can see here, now that they're all on the same slide, how these plan types may compare and contrast. Keep in mind that once you elect coverage during open enrollment or a special enrollment period, you are committed to that plan for a certain amount of time after confirming that coverage choice. So if this is a mid-year election, you'll usually have it until the end of the calendar year unless you drop the coverage for some reason. If your coverage begins January 1st, it will usually run through the end of the calendar year on December 31st. There may be exceptions to this, so just make sure you confirm your plan dates. A quick note here, healthcare cost-sharing ministries and short-term coverage plans do not meet the standards of comprehensive coverage. So if you're considering one of these, please be sure to do very thorough research before making your decision. These options do not offer much in the way of support or savings when it comes to chronic disease care and have other important differences from comprehensive health insurance. So be very clear on what you're looking at before you decide to move forward. Outside of the lack of coverage for people living with diabetes, it's important to note that in the state of California, opting into either one of these options and foregoing comprehensive coverage means that you will also owe a penalty under the individual mandate. With that being said, we can go ahead and move on to our next slide. We're going to talk about health savings and flexible spending accounts. So some plans offer these health savings accounts or flexible spending account options. You can see here on the slide some different points, how they compare and contrast. An HSA is employee owned and the account is portable. So this is something that is typically part of being enrolled in a high deductible health plan. It can be used to cover eligible medical, vision, or dental expenses. It can roll over if you don't spend the money at the end of the year. Some people use it as an investment vehicle because that's an option with an HSA. And the contributions are tax deductible or can be taken out pre-tax, and any withdrawals are tax-free. You can see here for 2023, the individual and family HSA max contribution amounts. So that is the max amount that you can have taken out pre-tax, or that would be tax deductible at the end of the year, depending on how your plan is set up. And then an FSA, which is listed there on the right side of the slide, is employer owned. So the account is not portable. If you leave that job, you cannot take the account with you. You can finish using the funds before you leave, but you're not able to roll it over. So you may lose any unspent contributions at the end of the year, or if you leave the job where that account is affiliated. You can use it to cover the same type of expenses as an HSA, but it must be offered by your employer for you to have that option. It does not offer any options to be used as an investment vehicle. But again, those contributions are pre-tax and the withdrawals are tax-free. So if you elect to have that money deducted for your paycheck for one of these accounts, it means that both of these options offer you a way to pay for health costs with money that you'd otherwise have to pay taxes on, since it lowers your taxable income. It's always hard to see money leave before it's even had a chance to hit your account, but keeping in mind that T1D and the cost of maintenance tends to cost more than the upper limit on account contributions, it's definitely worth considering if these are an option for you. Even in a lower tax bracket, you'll still save a good amount of money post-tax. Some employers also offer rewards for opting in, like maybe they'll add a little bit to your account or they have other incentives. So you should explore that with your plan options as well. And Dr. On, are you able to give us a little explanation of how this pre-tax deduction works on the next slide?
Yes, I can. And I hope this slide is right. But so just to provide an example of how these HSAs and FSAs can save money, practically speaking, in this hypothetical scenario, say you are a single adult making about $55,000 a year. That means your effective tax rate, federal and state, comes out to about 20%. Now, as Samantha already explained, the max contribution to FSAs and HSAs is about $3,000. So to make the illustration easy, let's say $3,000 you can put aside into one of these savings accounts. Now, that means that money is being taken from your paycheck pre-tax. So you don't have to pay tax on it. So if you did have to pay tax on it and you did not put it in such an account, you would really only end up with about $2,500 of that because 500 of it would go to taxes. So now you have an extra 500 in your account that you wouldn't otherwise have had. Now, the caveats with HSAs and FSAs apply. So, of course, it's not necessarily free money because there are some limitations. For example, if it's an FSA, you have to use it before the end of the year, and you may lose it if you switch careers. But as Samantha stated, most people with type 1 diabetes are unfortunately going to be spending at least $3,000 on medical expenses, whether it's seeing doctors, getting supplies, getting devices. And there are other non-type 1 diabetes related costs you can use this towards as long as it's health related. So since most people with type 1 diabetes are going to be exceeding this amount, you basically are going to be getting an extra $500 to spend on health related costs. So if your insurance plan offers this option and you have type 1 diabetes, it's very much it's most likely worth the effort to create that account and make sure that money's being pulled into it, because you save, instead of paying that $500 to the government for taxes, you get to use that on yourself for your health. Now, I'm not necessarily saying that the FSA plan is always the best plan to have if you have an array of choices, but if you pick a plan and you have that FSA option, you definitely should max out that FSA. Would you agree with that, Sam?
I absolutely would. It lowers your taxable income and it gives you that pre-tax money to spend, like you said, on all of the things that come up with type 1 diabetes throughout the year, co-pays, pharmacy pickup, which happens once a month for most people, or every 90 days if you're on that plan. And certainly, like you said, there are a lot of other non-diabetes related expenses that we still have because we are human beings who have diabetes, but we also have other things we need to take care of. So one way or another, you're going to be able to use that money to your advantage. Heavily worth considering. All right, next slide. Calculating the annual cost of your insurance can be a little bit of a challenge, but here are the important things that you would want to start with when taking a look at that. So we want to look at insurance premiums and the deductible. So your premium is paid monthly, either directly from you to the insurer, or it's deducted by your employer from your paycheck. And this is the cost to maintain the policy. The deductible is the amount that you pay before the insurance starts paying towards your claims. When you look closely at the summary of benefits, and more specifically at the areas that you know you utilize on a regular basis, you can get an idea of how quickly you might get to your deductible, after which point your coverage will pay the agreed upon amount. There may be some exceptions about what counts toward the deductible, both in a positive way. So for example, let's say your copays apply prior to meeting the deductible, so you don't have to pay the full amount for your prescription items until that happens. Or it could happen in a negative way. So certain procedures, including out-of-network care, won't count towards your deductible. You may be responsible for different amounts of copays or co-insurance pre and post meeting your deductible. So this is the amount of money that you will pay per visit or service that is not paid by your insurance. Clarify with your insurance ahead of time in case you have a separate prescription deductible. Some plans may also allow you to pay a copay from the beginning of the plan, making your prescription costs exempt from the deductible. So there's a few different things that can vary here. Next slide.
Sorry, to add one thing to that, or to kind of reiterate,
Yeah.
the deductible is probably going to be it's going to play a huge role in your costs. And the challenge is, as Samantha so eloquently said, that every insurance plan defines and applies the term deductible differently. So you can't even necessarily, unfortunately, just say, oh, there's a 3,000 deductible with this plan and a $4,000 deductible with this plan. Unfortunately, you have to really understand the intricacies of how that deductible is going to be applied, because there's so many different tricks and so many different ways that it can sometimes work in your benefit or work against you, as Samantha stated. So I can't emphasize that enough. Unfortunately, all deductibles are not created equally.
No, they are not. Absolutely important to note all of that. It's a piece of information that you need to have to begin that journey of figuring out what those costs might look like and how quickly you'll be on the hook for that amount of money. So, of course, talking about cost, we also want to talk about controlling the cost. So one way that you can do that is by utilizing in-network providers and in-network services versus opting for out-of-network providers or services. So in-network means that that entity, the physician, the hospital, the device manufacturer, the pharmacy, whatever it is, it means that they are contracted with your insurance, and those items are typically subject to your deductible and oftentimes contribute to your out-of-pocket max, which is something that we'll be talking about shortly. Whereas opting for out-of-network care means that that entity is not contracted with your insurance, and you'll either have coverage at a smaller percentage or possibly not at all. So very straightforward. If you choose in-network providers, labs, doctors, pharmacies, equipment suppliers, etc., you will save significantly in comparison with going out of network. Some plans, again, they just don't have any out-of-network coverage, so you want to make sure that you understand that in advance. Next slide. Surprise billing. This is something that's also known as balance billing. It's happening, I think, a little bit less than it used to because of some of the healthcare policy shifts that have happened over the last few years. An example of this is, let's say you go to an in-network hospital, but you end up being treated by out-of-network providers outside of their ability to let you know. So let's say that you end up in an accident and you end up at the hospital and an anesthesiologist ends up coming in to treat you and they're not contracted with your insurance. Or another example, an in-network lab or imaging center that you verified with your insurance was all good. You go there and the doctor who reads your results is out of network and you get billed. Surprise, you weren't expecting that. In an emergency, you get taken to the ER and that facility that the ambulance took you to is not contracted with your plan. That's another place where you could end up with that surprise billing. So in the past, you would have been on the hook for that. You would have been on the hook for the balance of whatever your insurance didn't cover. And now there's a California consumer protection, which ensures that patients only pay their in-network copays, coinsurance, or deductibles in these situations. So that's something to be aware of. If you do get one of these balance bills or surprise bills, you can call and talk through that because that's not something that you're going to be responsible for. Next slide. So we talked a little bit about deductibles, which is that amount that's paid out of pocket by you as the policyholder before insurance will pay any expenses and is the threshold amount for that policy payment. And then there's also the out-of-pocket max, which is another important number to take into consideration when you are considering insurance plans. So your out-of-pocket max is the most that you're going to pay towards your medical costs for the duration of the policy year. So once that out-of-pocket amount is met, your insurance covers things 100%. Of course, this is only applicable to services that are covered under the policy. So in some cases, let's say you decide to pursue out-of-network care, that money may not count towards your out-of-pocket max. You would need to verify that with your insurance company. But what you're really looking at is wanting to make sure that you can cover the amount that it takes to get from the beginning of the year to the deductible. And then once you meet that deductible, that you'll be able to maneuver within the copays and co-insurances and the other amounts that you'll be on the hook for before meeting the out-of-pocket max. And then once you meet the out-of-pocket max, everything else that's in network with your insurance will be paid for by your insurance at 100%.
So this can really come in handy if you're recently diagnosed with type 1 diabetes, because you were probably, or many people end up going to the hospital when they are first diagnosed with type 1 diabetes. And those hospital bills, unfortunately, add up to be quite high fairly quickly. And so if you do hit that out-of-pocket max, it's really important to realize that now everything for the rest of the year is basically free, as long as it's something that's a covered benefit. Of course, you can't, all of a sudden get plastic surgery or something. But if it's, a medical benefit, then it should be covered 100%. So especially more expensive things like insulin pumps, for example, like a Tandem or a Medtronic insulin pump, you pay for the bulk of the cost up front. So timing that really comes into play because that might be like a $3,000 or $4,000 purchase. So the difference between doing that in December or January can make a lot of sense if you're trying to potentially hit the out-of-pocket max for that year. So if you've already hit the out-of-pocket max, then maybe you want it to be in December so that you get it for free. If you didn't hit your out-of-pocket max, but you anticipate that you're going to have a lot of costs incurred the next year, then maybe you time it so that you get in January so that you can try to fill the, get to the out-of-pocket max for that next calendar year. So that's why the out-of-pocket max can matter a lot, especially when certain things in type 1 diabetes can be costly, like hospitalizations or pumps by certain models. I say certain models because things like the Omnipod is more of kind of a pay-as-you-go, so it's pretty evenly distributed, whereas the tubed pumps tend to be a very big purchase in the beginning, and then you just pay a smaller cost for supplies. But Samantha, there was a good question that came in that I wanted to see if you can answer. So going back to the in-network discussion, the question is, does in-network terminology also apply to DME companies? So for example, patients that are getting Dexcom supplies from a durable medical equipment supplier, are there in-network and out-of-network DME suppliers as well?
Yes, there are. Excellent question. So some folks may have been told they only have the option of one DME supplier. It's possible that your insurance company is only contracted with one, or it's possible that they only told you about the first one on the list when you called. So you can definitely ask for a list of all of the in-network DME providers with your insurance. And it's important, unfortunately, it really is on the patient to verify that information, both with the insurance company and with that DME provider when you do place the order, you have your prescription sent there, because sometimes those contracts can change from year to year. So you want to make sure that you know who's in network, you're utilizing an in-network provider, and that you are making sure that your prescriptions are maintained through an in-network provider. So from year to year, that could vary. Maybe this year it was one company and next year that company is not contracted. So just make sure that you're keeping on top of what that list is and make sure that you're getting the supplies from the right place so that you can get the full benefit of whatever your DME coverage is, and that you're not dealing with a surprise of a lack of coverage or less coverage than you were expecting.
A side note when it comes to DME suppliers, and I know we'll talk a little bit about this later, is that unfortunately, pretty much I feel like I've heard horrible things about all of them. So unfortunately, it's not one of those grass is greener on the other side things oftentimes. So if part of your issue that you're looking elsewhere is due to kind of frustration with the ordering process and lack of communication and frustrations, unfortunately, I think it's pretty common across all in DME suppliers. It's kind of, I don't ever hear really positive stories. Of course, I can't guarantee it's horrible with every DME supplier, but it does tend to be a common pain point for patients. So, unfortunately, I don't think it's a situation where like your specific one is just bad and switching to the next one will be better. I don't know, Samantha, how's your experience been working with DME suppliers?
Yeah, it's been a challenge. I've had some occasions where things have gone smoothly and other occasions with the same company where it has not. I've worked with a variety of them over the years due to switching insurance and having different insurance plans, different contracts. They all kind of present the same challenges across the board. And my only advice, aside from what we just talked about, as far as protecting your interests financially with that, is try to be patient, take great documentation so that your records are impeccable in case something goes awry and you need to, um, follow that up. You can follow your timeline really clearly and just give yourself as much time as possible. I know a lot of us are very, very busy, and diabetes hopefully isn't, the top of mind all of the time. You're outliving your life. Also, what can happen sometimes is while we're outliving our life, we're running out of supplies and we're forgetting that we need to reorder, or we haven't gotten onto an automated refill, or maybe we don't want to be on automated refill because we've had a bad experience with that. That happens too. And so we can run out of supplies and then we're on a crunch to get that filled. And that tends to be when we have these issues come up with the suppliers. So if at all possible, set a reminder on your phone, put it in your calendar, make sure you're staying on top of those DME supply orders. If you can, get on top of it in advance so that you know what day it's supposed to ship out. And if it doesn't, you can call and follow up on that. Basically, anything that you can do to try to prevent issues from coming up is going to be really worth your while. It's not our job to do that, of course, but also at the end of the day, as the patient or the person who's providing care to someone who we love who has diabetes, if we wait on these things, we'll be the ones who suffer. So being proactive and taking lots of good notes would be helpful in this wherever you are across the board.
Yeah, that's really great advice. Like to reiterate that, like if they tell you they're going to do something, if they're like, "Oh, we'll ship it out tomorrow," or like, "Oh, we'll fax, Dr. On's office that paperwork," you should call my office. Unfortunately, you should double check that they're shipping it the next day because so many times, I don't know what happens, but it somehow gets lost in the ether, and then the next person you talk to on the phone has to pick up all the scraps. So definitely be proactive. So interestingly enough, a follow-up question we kind of anticipated, but they actually had a different experience. So they said that, in this specific example, they had a really bad experience with one provider, Byram, but they've been having a great experience or had a previous great experience with a different company, Advanced Diabetes Supply. If they feel very partial towards one DME supplier, is there a process to appeal to their insurance company to have one preferred over the other? I don't know if you know the answer to that.
My understanding with this, and of course this there could be more to it, but that this is actually one of those areas where it kind of is how they say it is. It would be one thing if your insurance company said, we're not contracted with any DME suppliers. That is probably not correct. And you would definitely have grounds to say, okay, but under the Affordable Care Act, like you have to cover these items for me. You can't discriminate against me based on my diabetes. So what's the plan here? I'd like to use this particular company. But if they're offering you a comparable, what they consider to be comparable, you may not consider it to be comparable solution. I don't think that there's an appeal process. But here's what I always think about with these things is it doesn't hurt to ask. You can make the phone call, you can send the email, you can even talk to someone at the preferred company and say, hey, I've had really great experiences with you in the past. My new insurance says they won't work with you, or my insurance says that you're no longer part of the network. Is that accurate? Is there anything you can do so that I can stay your customer? That's going to motivate that company to do the legwork for you. They want to keep you as a customer. So, you know, don't take the first no. You can certainly investigate. Any other follow up, Dr. On?
No, I thought that was a really good discussion, and it is very important. We'll talk a little bit about it later, but DME is playing a larger and smaller role in type 1 diabetes. But yeah, definitely something to be very familiar with.
Great. All right, let's hop on over to the next slide. So the word formulary, this is going to come up a lot in type 1 diabetes and insurance, if you're on a prescription medication, that is something that you need to be familiar with. So the formulary is the list of drugs and also some other items that your insurance company covers, usually listed in tiers, tier 1, tier 2, tier 3, et cetera. And these tiers define your least costly options up to the most costly options. Choosing generics, biosimilars, and or tier 1 drugs can be a source of cost savings. So that's something to consider with prescription items. This is also a great time to mention that pharmacy benefit managers exist. These are often referred to as PBMs. You may have heard a little bit about PBMs in the recent conversations around insulin affordability. These are third-party benefit administrators that are involved with things like creating and managing formularies, negotiating discounts and rebates with manufacturers, which unfortunately most of the time don't get passed on to the patient, as well as processing and paying benefit claims for prescriptions. So 3 major PBMs that you may be familiar with are Express Scripts, so that's one that's owned by Cigna, CVS Caremark, which is part of CVS Health, and Optum Rx, which is affiliated with United Health Group. We will definitely talk a little bit more about prescription items and things that interact with that formulary a little bit later on. We're going to talk about something else on the next slide. Mental health coverage. So this is something that may not naturally come to mind when you're thinking about type 1 diabetes and insurance. And I think this is something that we need to make sure that we're making part of the conversation about the holistic approach to care for individuals living with chronic illnesses like type 1 diabetes. So it's important to note that, again, under the Affordable Care Act, something that we're talking a lot about tonight, because that's kind of the new overarching umbrella that covers most health insurance now, mental health and substance use disorder services and prescription drugs are part of what they call the 10 essential health benefits, or the things that have to be included with an ACA compliant insurance plan. So in addition to that, there are no lifetime limits or annual limits based on mental health services, and they have to be covered at the same level with other medical services. So it's not to say that it makes it very easy to access mental health coverage. There's definitely a shortage of mental health providers, and even once you find someone who's contracted with your insurance, it could take a while to get in to see them if they're taking new patients or not. But the important thing to know is that your plan does offer that kind of coverage, and you should pursue it if that's something that you have considered or that you've done in the past, or for any number of reasons that you might go looking for that. Living with type 1 diabetes can be extremely stressful. Being a caregiver to someone who lives with type 1 diabetes can also be stressful. We also are living in a stressful time. There's a lot going on in the world, and we all have the different things that are going on in our personal lives, and we can benefit from a check-in, whether it's just once in a while, with someone to talk to and say, hey, how am I doing? Is my diabetes, triggering some burnout, anxiety, depression, an eating disorder? There are so many things that people with diabetes are at a higher risk and need to, stay on top of with their care team. And also, sometimes it's just helpful to have someone to talk to about the things that are coming up in your life. So just wanted to make sure that we covered that topic. You have mental health coverage if your plan is considered comprehensive health coverage. And as a person with type 1 diabetes or a caregiver to someone with type 1, it's very helpful to look into that coverage and utilize it if necessary or desired. Next slide. Non-medical switching. So this is a phenomenon that occurs when a patient's medication or therapy is changed for a reason other than the patient's health and safety. So you might get a letter from your insurance that says, as of this date, we are going to be switching you from Humalog to Novolog, or Novolog to Humalog, or Lumjev to Fiasp, or Fiasp to Lumjev, or any number of these different drugs or therapies that are considered to be the same by your insurance company may have some small changes that you may or may not notice. This can occur mid-year, and your insurance company is supposed to give at least 30 days of warning in writing, usually. So this is something, Dr. On, I would be curious if you wanted to weigh in on and just kind of give a little bit of information from the physician side about non-medical switching, both how it could be totally fine and maybe in a situation where it's not fine, what recourse there is to handle this.
Yeah. So of course, this is, very annoying for everybody, because, it's annoying for patients because what you're very familiar with, like a lot of times patients are like, hey, I've been on Humalog my whole life. I've never tried Novolog. I don't want to switch. And then for my office, it's obviously a burden because, 20 patients now need different prescriptions or are very confused. So never fun for anybody. And what I generally will say is that I think for like 90% of the population, it's probably easier just to follow your insurance company, because it is true. Like for most people, Humalog and Novolog work very similarly, and it's not super noticeable. But at the same time, there are a small percent of patients who, really feel like there's a big difference between how Humalog works versus Novolog. Or I've had patients that have rashes to one and not rashes to the other. So obviously, if it's a scenario where you've tried the other one and it definitely didn't work out, for whatever reason, then we can, there is recourse we can do. We can do what's called a prior authorization, where we can say, hey, my patient tried switching from Humalog to Novolog and they had a really bad experience. So that's why they need to go back to Humalog. Or I can say, this person tried Novolog back in 2015 and they had a horrible rash. So we don't want to try it again because, the same thing's going to happen. So there is a possibility to try to stick to the medication that you were previously on. But for, practical reasons, I would at least give it a try first to see if it is a fairly seamless experience. And then if it's not, then know that you have to stay on your preferred brand for the future. And then two, there is a recourse that there is an option for us to try to get you to stay on it. Oh, and one thing to say is it's much easier to get that prior authorization approved if there's proof that you tried it and failed it, right? So, a lot of times my patient says like, hey, I've never tried Humalog. It's hard for me to write a letter to your insurance company being like, this patient needs needs Humalog because they don't want to try Novolog. Like I get it as your friend and as your provider, like that makes perfect sense to me. But from an insurance company, that usually isn't a very compelling reason. So even if you just try it once and have a horrible experience, like that at least is a much more justifiable reason to an insurance company versus, you're just not wanting to try out a different insulin. It's annoying, but unfortunately, that's just kind of a practical consideration.
Yeah, that's important to keep in mind, all those different possible scenarios. It's so frustrating for patients when they are switched because of preferential pricing that's arranged with the insurance companies and not due to something that they have had the opportunity to work through with their physician. But it is kind of a thing that comes up pretty frequently in diabetes for certain, as well as other health conditions. And one of the words you used actually made me think of another like phrasing that we sometimes hear with this. So non-medical switching is something that you will hear a lot, as well as fail first. So like you said, if someone tries something and it doesn't work, then the insurance company will approve something else. And there's definitely a patient advocacy movement that's not for fail first therapy, because that can obviously delay people from getting what they need or keep people from getting, continuation of care or whatever. But those are things that we do need to keep in mind. And like you said, documentation is so key if that is something that you are planning to appeal with your insurance company. So do keep note of those things and make sure you communicate them to your provider. So that way, if they need to go to bat with a prior authorization or a peer-to-peer or something like that, that they will have all of that information so that they can advocate on your behalf.
A few things to add in addition is sometimes it actually works in your favor. So I've had, probably not often, unfortunately, with insurance, but I've had patients that were on, an older insulin, and it turned out that there was a brand of insulin that their insurance preferred that I actually think works better. So, like for example, Tresiba is kind of what I consider a top tier long acting insulin. And so, there are a few patients that wouldn't have known or even thought to switch to Tresiba, um, if it wasn't for their insurance kind of changing their formulary around. Similarly, there's also this weird world where sometimes the generics are the actual exact same molecule. Like literally, it's bottled at the same facility, made by the same exact manufacturer with a different label on it. So, for example, Humalog, there's Lispro, which is the generic version of Humalog, but it's actually made by the same company, bottled at the same factory, literally with just a different label on it. So in that situation, I try to tell my patients, like, really, it's no different. Like, don't like, let's just go with the flow, because it literally is the exact same thing with a different label on it. And it's a perfect representation of how crazy insurance and pharma is. But yeah, so it's not always a bad thing. But often, of course, it's very inconvenient for sure.
That's everything right there about non-medical switching. So we'll continue thinking about how to navigate these decisions around selecting coverage on the next slide. So here are some things to think about with that. Some questions to ask yourself. Maybe as a person who with diabetes would likely have a moderate to high health plan usage throughout the year, how can you save the most money and get the most quality care over the entire year? Oftentimes, unfortunately, people with type 1 diabetes may also have other autoimmune conditions, or maybe things that have nothing to do with diabetes that are part of their health and wellness routine that they need to be managing throughout the year, keeping an eye on. So it's important to look at the big picture. If you can, try to sketch out the planning of major purchases throughout the year so that you can maximize your coverage and benefit from hitting that out-of-pocket max, just like Dr. An was talking about earlier. It's also important to consider anything out of the ordinary in addition to your planned healthcare spend for the year ahead. So for example, if you or your spouse are planning on a pregnancy or a scheduled surgical procedure, you'll want to take that into account as well, especially if one of your plans, if you are a couple and have the ability to choose between one person or the other, if that person has better coverage for these particular events, then you might switch for the year, or maybe find that that's a better plan overall for you and your family. It can also be really tempting to scan that benefits information that we were talking about, that summary, and let your eyes go straight to the lowest premium number you see and just call it good. I would advise that you definitely take the time to consider not only the monthly premiums, as we talked about, also the deductible, out-of-pocket max, the copays for your most frequently filled prescriptions, like insulin, for example, and all of the other things that go into your healthcare spend for the year. So on the next slide, we'll talk about a couple other considerations. If you are employer insured, so you receive your insurance through work, you may be able to speak with your human resources department or your benefits manager regarding policy clarification, and maybe even get some help with certain coverage related issues or concerns. I've heard of situations where an employer provided plan didn't cover a certain medical device that a person with diabetes needed or wanted, and they were able to let their benefits manager know, and they were able to get that resolved so that they could get coverage. So that's definitely something to keep in mind if that's coming up for you or you're having some issues. They don't know if there's something that's not going well for the employees unless you tell them. So if these are things that are coming up for you, definitely communicate and see if you can get some assistance. And on the flip side, if you're someone who's self-employed, you may be able to deduct the annual premium amount from your taxes. So that's something to talk to your CPA about and see if that could potentially benefit you. All right, we're going to hop into the next section of our presentation about navigating coverage. We'll just jump straight in to the next slide after that. Do some digging, very basic, asking questions, but this is so important. You never know what you might find out that could be helpful for maximizing your coverage if you don't ask. So for example, on our next slide, I'll give you a little idea of what that could look like. Some people with plans, usually employer sponsored, find that those plans cover certain diabetes management items or types of insulin to be considered preventative. As people living with diabetes and people who care about those who live with diabetes, we already know that consistent and thorough diabetes care is a type of preventative care, but it isn't always acknowledged that way when health insurance is involved. So if you have a plan where this is the case, you would definitely want to find out, because that would make a big difference to you. In this type of situation, spend towards insulin and some diabetes management items are not applicable to the deductible, but in that positive way, meaning that insurance will start paying towards them on day one. In some cases, there's a reduced cost. And in some cases, I've even heard of people having no cost for their diabetes care items through a plan where they consider diabetes care to be preventative. So this development is very good for people living with diabetes and their families. Definitely want to find out if your plan or any of the plans you're looking at are taking this progressive approach to diabetes care and preventative care. Next slide. So we've had some questions come in talking about DME suppliers, and we're going to talk a little bit about that now. So getting your supplies from a manufacturer directly versus a third-party DME company versus a pharmacy. When it comes to your insulin pumps, your continuous glucose monitors, any associated supplies, you want to know in advance if your insurance company has any kind of quirks in their device coverage. Some examples here, this may or may not still be the case depending, at this point in the year, but Anthem Blue Cross, for a period of time at least, did not cover Omnipod through pharmacy benefits. And we'll talk a little bit more about Omnipod specifically in the coming slides. Past United Healthcare exclusivity deals with Medtronic. A lot of us are familiar with what that looked like. Only certain insurance companies will cover Eversense. There's a lot of different things that it's important to be aware of as far as both what's covered and how it's covered, whether you can get it directly from a manufacturer, if you need to go through that DME provider, if you need to order from pharmacy, and the difference between DME and pharmacy often being that DME is under the medical coverage and pharmacy benefits are separate. Next slide. So here are some things to consider when we're looking at this topic of where you're getting these supplies. Verify while you're still on the phone to make sure that the supplier that your insurance has given you is actually a diabetes, DME, or pharmacy supplier. So this is what you need to do when you ask your insurance for that preferred in-network supplier list, like we were talking about earlier. I have told this story a few times, but I think it's still worth repeating. One time I called my insurance company at the time. I asked them for the DME recommendation. They told me, call the Hanger Clinic. And I said, okay, great. And I called the Hanger Clinic and I told them what I was looking for, and they had no idea what I was talking about. And it was then that I Googled the Hanger Clinic and found out that they are an orthopedic DME supplier. So they don't cover any diabetes supplies. They don't offer them. They have no idea what that is. And I had to go through that process all over again and call my insurance company because they didn't give me the right information and I didn't verify with them while I was still on the phone. Now, if I get a name over the phone, I'm going to be in front of my computer and searching for that provider while I still have that insurance member representative on the phone to make sure that I'm getting all of the information that I need before I hang up.
Yeah, one thing I'll add there is this is where it's so horrible, because it's like, even if you're trying your best and you're calling your insurance company and trying to get answers, a lot of times the person you're talking to is not ridiculously helpful, or they don't understand the nuances of type 1 diabetes with all the different devices. They don't understand what they are. And so it's very important to try to tease that out really fast, like how, like there might be a person on the other line who it's their second week and they're, following the script. And so they just don't know things, versus the person that's been there 20 years and maybe has a daughter with type 1 or something like that. So, it's really important to kind of validate and kind of understand what these people know. So yeah, so I think that's really really important to make sure they are trustworthy sources.
Absolutely. Like you said, you want to see if you can run into someone that knows what you're talking about. Um, it's important to know the difference between durable medical coverage and pharmacy benefits. There really isn't a rhyme or reason as to why some plans have one or the other or both. It has more to do with the cost of the insurance, the PBMs, deals between the insurance company and certain providers. It's really important for you to know what options are available to you and at what rate. So call your member services. You can ask them for the NDC numbers in advance so that you can provide them on the call to verify the cost when you speak with someone who doesn't have any background on the names or the types or the pieces of the systems that you're asking about, kind of like what Dr. An was just saying. And an important change in the past year in regards to DME versus pharmacy is that Dexcom and Omnipod specifically have shifted coverage for certain products. So specifically the Dexcom G6 and Omnipod 5, where other products from these manufacturers like Dexcom G5, Omnipod Eros, and Omnipod Dash were more flexible in what type of coverage could be used. This has now changed. So this looks like it's a trend going forward, and you'll want to pay more attention to your pharmacy coverage for these items as part of evaluating benefit options and costs for this year, because if you're paying a copay every month versus having your DME covered at 100% or some other low percentage, that's going to be a change for you. So some people have said the plus side of that is that they get to deal with their pharmacy instead of DME providers. So I know we've had some folks that were, not thrilled with their experience in the past. So maybe that's a plus. But either way, it's something to be aware of. Another note here is that manufacturer reps can be really helpful in navigating this process. They're incentivized to make sure your purchase goes through. So if you're having an issue and you aren't sure who to work with or how to make it go faster, definitely reach out and let them know that you're having a problem so they can try to assist. Next slide. So if you're going through a pharmacy for things like insulin or other medications or these devices that we were just talking about, it's important to know if your insurance company has a preferred pharmacy. They may have in-network and out-of-network. Your insurance may also offer you a deal on those items if you order through their mail order pharmacy or in certain quantities. So if you do a 90-day instead of 30-day amount of your prescription. And some pharmacies are more responsive or have more capacity to coordinate the challenges of diabetes prescription coverage. So that's something to keep in mind. Next slide. Different types of pharmacies. Mail order, we talked about CVS Caremark, Optum, RX, etc. You have your local neighborhood pharmacies. We've got Mini Pharmacy here in Southern California, ABC Pharmacy, your Good Neighbor pharmacies. Of course, you have your chain pharmacies, CVS, Walmart, Walgreens. And of course, there's also kind of this hybrid that's popping up. One that we deal with a lot here at the center is Alto Pharmacy. So they are a local pharmacy that does not have any in-person locations. You just get the prescriptions delivered to your house, but it's by courier and not mail order. And they have different locations throughout the country where that's available. Next slide. With prescription items, some things that we want to make sure that we're aware of are things like step therapy and prior authorizations. So step therapy ties in with that non-medical switching or fail first therapy like we were talking about. From the insurance side, it controls costs and risks, but it can be frustrating and potentially harmful and time consuming for both the patient and their physician. Prior authorizations, like Dr. An mentioned, requires the doctor to get permission before the plan will cover. It involves paperwork and calls. Something called utilization management is involved in that process. And the insurance looks at it as a safety and cost saving piece. So that's what they're looking at. And then as a patient, unfortunately, sometimes that can be costly and time consuming for you and also your physician. If you have an issue and you need to appeal, first, you should inquire whether the rejection of the prescription item is in fact based on policy coverage, or it could just be an administrative error or confusion with billing. And it's also possible that your policy covers the item in a different area. So again, this is like a DME versus pharmacy thing. You could get a claim rejected from DME because it's supposed to get sent to pharmacy. So you just need to make sure that it's being run through correctly. And if it isn't easily fixed by running through these possibilities, talk to your pharmacy, your device reps, and your physician's office to help you take the next steps in case it does involve prior authorization. Any additional comments on that, Dr. On?
Yeah, I think that's a great point. What you were saying, where like a lot of times you feel you might be told that it's not covered or that it's ridiculously expensive because they're just not doing the DME versus pharmacy thing right. Now, of course, unfortunately, insurance, insulin pumps and CGMs often are expensive, but sometimes, they just don't know to check the other channel, right? So they only look at the pharmacy benefit and maybe it's not covered. So they just give you the full price, but maybe it would be heavily subsidized if you go the DME route, and same thing vice versa. So, like Samantha said earlier, I really would say, especially with the devices, to rely heavily on the company. Like, so say you're trying to get a Dexcom, like rely heavily on the Dexcom salespeople, because the Dexcom people want you to get on Dexcom. So they're going to try to get it as cheap to you as possible because that will, increase your chance of purchasing their product. So that, that's kind of the people I would turn to for help if you're trying to get a specific device, is really reach out to representatives from that company.
Absolutely. This is something, I think many people with diabetes or their loved ones who've gone to the pharmacy on their behalf have experienced. They go to pick up a prescription or they go to order a prescription and they're quoted an astronomical number. Unfortunately, sometimes that is the number, and that's a conversation for another day. But a lot of the times, our first reaction is to panic, freak out, cry, yell at someone. And it's really, really beneficial if we can just kind of take a breath for a moment and look at, like, what are the questions we need to ask around why this happened? Because it could be something really simple and someone just made a mistake. Don't walk away from the pharmacy without your prescription. Try to work it out, because that's something that often can be worked out fairly easily. It just takes a moment. And obviously, you are there because you need the item. So let's make sure that we're giving ourselves the time and space to make sure that we can make that happen. All right, we're going to keep moving along here. Next slide. Talking about focusing on your health and well-being in this regard. Next slide. Insulin access. Dr. On, I'm going to pass the mic over to you.
Yeah, so these are just some practical tips to consider. Insulin is, of course, by definition required, right, for the management of type 1 diabetes. So you definitely do not want to restrict your insulin. I'm sure you've heard headlines, or maybe you've done it yourself, but rationing insulin is a huge problem. You don't want to reduce the quality of your care just because of access issues. So things to, potentially help you maintain solid access to insulin. Don't be shy requesting samples from your physician. We usually have samples of most everything. Now we even have devices, right? So I have Dexcom samples and Libre samples. I don't have pump supply samples very often, unfortunately, but pretty much anything else, there are going to be samples available from your doctor's office, and your doctor doesn't pay for them, right? So it's not like I'm purchasing this and giving it to you guys. It's given to me by the company. So, it's like the t-shirt cannon person at the stadium, right? Like they're happy giving out the t-shirts. So I'm happy, making my patients happy by giving out stuff. So, in the end, of course, it's not like, I can't bankroll everybody. I would love to help all my patients never have to go to the pharmacy ever again. We do get limited supplies of samples, but if it's affecting your health, like please let us know as your providers, because often, we can try to get you some samples to write it out. Like I said, I can't, give you insulin for the next year, but if it's like a couple pens to get you to your next fill or something like that, like usually that's doable. Also, patient assistance programs are available. Pretty much every pharmaceutical company, I think they're required to have them, but there are special ways for you to get free medication if your income is below a certain poverty line. So if you do not have good access to, like if you don't have, if you're not making enough money, a lot of times there's an application that you can fill out on these websites, and they will give you free supply. They're kind of hard to get to and not super easy to apply for. But if that defines you, I think it's definitely worth the effort to try to put in to get to that. Now, also, there are also something called 340B pharmacies at federally qualified health care centers. So locally, for example, SOS is a clinic that's government funded to help people that are underinsured. And these special clinics for underinsured patients often have medications, like good prescription medications that are kind of pennies on the dollar, because they're provided at a very heavily subsidized cost by the government. Furthermore, there's also often free clinics and run by local charities. At the Diabetes Center, we actually have something called the Insulin Relief Fund that we started during COVID to help people that were losing their jobs. Basically, if you are in need of donated insulin, please reach out to the Diabetes Center at diabetescare@hoag.org, and we may be able to give you a limited supply of donated insulin that was purchased by philanthropy to kind of help you during difficult times. It is intended for underinsured people. It's not kind of a free for everybody, but if you are in need, that might be a great place to look, diabetescare@hoag.org, and ask about the Insulin Relief Fund for donated insulin. Next slide. So also, manufacturer coupons they can be very helpful if you have commercial insurance. It's kind of frustrating because they're not obvious to patients, and no one is going to tell you at the pharmacy that it's cheaper with a coupon. It's kind of like going through the drive-through lane. If you at a fast food joint, they won't tell you that there's some deal for 2 tacos for 99 cents. They'll just make you pay the full price unless you know about it. So it's kind of the same deal with these coupons. So if you have any prescription medications, I would start by going to the official website for the medication. So every brand name medication, you can basically just type it in add a .com, so humalog.com, traceba.com, and there's usually a website put on by the manufacturer, and they will almost undoubtedly have a link somewhere that says savings, and then you click on it and they'll have some sort of coupon program available. Because of the scrutiny on insulin, from the government and from the mainstream media, and with COVID, there are actually a lot of discount programs being offered that aren't necessarily patient assistance. So even if you're making a good income, there are options to get insulin at a much more affordable price. But unfortunately, it's not like ridiculously obvious. So the best place to start would be to go to the official manufacturer website to try to find those deals. Also, to browse coupons, GoodRx is a pretty decent website that has a lot of coupons, but they don't have every coupon. So if it's not on goodrx.com, that doesn't necessarily mean there's not a coupon. Next slide. So here's some insider tips that I can share, I guess, being on the provider end. So some of these Samantha can also pitch in on, but utilizing reminders and auto refill can be very convenient. Things can be annoying with getting prescriptions filled. So removing barriers, and so there's no gaps in your access to insulin, is very important. Also, when we as doctors write prescriptions for insulin, it's always very important to make sure that your doctor is writing for enough insulin to cover what you normally would take, in addition to more than that, because there's always unanticipated issues, or if you're sick, you're going to need more insulin. So I always try to write for prescriptions higher than their typical daily dose of insulin to anticipate these issues that may come up. And that's perfectly legitimate because, as we stated, sometimes, things come up and you need access to insulin. So make sure your doctor is writing you enough insulin to get you through a typical, month, plus, for unexpected issues that may arise. Also, in line with this whole like maximizing your insurance, just because you have enough insulin in your fridge, it may still be worthwhile to make sure you're filling it every month. Because maybe you've hit your out-of-pocket max for the year, and you want, every month that you fill your medication, it's going to be free. So just because you have enough to last you for the next month, that doesn't mean You shouldn't continue to fill your prescriptions on a regular basis because you want to maximize what you have. As
Sure.
we stated before, getting in touch, their drug and device reps are your friends because they're motivated financially to help you. Planning ahead is really important, being super organized, creating a paper trail, really not taking anything people tell you over the phone as 100% gospel truth, and kind of verifying things are very important. I can't tell you how many times patients have told me, the pharmacy told me they faxed you my paperwork 3 times already, or, Byram told me that they faxed you this form and that your office is not responding. Sometimes that is true and my office doesn't respond, but I would say about 80% of the time I look in the fax machine, I ask all my staff, and we never received a single document. So I don't know what's happening to those. I'm not accusing people of lying, but I can definitely say oftentimes they're not received. Um, Another point that I will really like to highlight is to be honest with your doctor about affordability concerns. I have no idea how much my patients pay for medications. Sometimes I find out that they just bought their insulin at like full price, $800 a month when there was a $99 a month option. They just didn't know about it. And they thought, hey, I hear insulin's expensive. So I just thought I had to pay $800 for my month of insulin. But I'm like, no, we could have just switched your insulin to this other insulin and it would have been 75 bucks. So, sometimes it's just people don't know, and your doctor may be more aware that there may be a more affordable option. Also, uh, we don't, it may be embarrassing for you to mention, but we just don't know what your situation is like. I don't know whether, your Dexcom is going to cost you 400 bucks a month or whether it's going to be free, because for some patients it's free. So, or not free, but you don't have to pay anything with your insurance. So knowing where you're at and knowing what is you're going to have to pay is very, very important to us as we make decisions, because then we can, like the Libre 3, which just came out. It's a pretty awesome CGM that probably provides 95% of the benefit of the Dexcom. So if the Libre 3 is going to be 5 times cheaper for you than the Dexcom, then maybe the Libre 3 is a great option. So, cost does play a huge role in these decisions. So please, try to make your care team and prescribers aware of where you're coming from. And we want to know and we want to help you as best as we can. And also staying patient connected with the patient community is so key, because there's so many things at the doctor's office we don't know, right? We don't live with type 1 diabetes ourselves. So there are small things, small hacks, small frustrations that I think you can get a lot of support for from the patient community. Samantha, anything you wanted to add?
Yeah, just in line with what you were just saying about the patient community. Of course, here at the Diabetes Center, we have support groups to help connect people. Right now, they're virtual, so even if you don't live near here, you can definitely join us and register online. If you want to connect from a distance and you're not as much into like the support group format, there are online communities, Facebook groups, forum boards. People, like, I guess, hang out on Instagram and TikTok and all different types of places now. And something else that we noted here that I think is also important is taking advantage of any wellness benefits that your insurance company might offer, your employer might offer to help defray the cost of your premium in some cases, or just sometimes they'll give you more money to spend on healthcare expenses, and we can always use more of that. So definitely look into it. I'm going to go ahead and run us into the next slide, talking about resources. Again, the Insulin Relief Fund for folks who are at risk of rationing insulin due to financial concerns. Please do reach out to us here at the Diabetes Center. Dr. On mentioned GoodRx, other discount programs if you are a cash pay patient who's looking for the best way to maximize that spend. You can get covered through Covered California, Medi-Cal, as far as diabetes organizations that can provide some additional support. JDRF and the American Diabetes Association are two notable ones. Obviously, there are so many organizations now that are working to help support people with type 1 diabetes just across the board in different communities, mutual aid, all different types of things. So just please know, whatever it is that you're dealing with in regards to insurance and coverage and access to supplies, there's someone who can help. There's an organization that can help. There are resources. And I know Dr. On mentioned sometimes folks are embarrassed to mention, like, hey, I'm having trouble with this, or they also sometimes say like, oh, well, I feel like other people are suffering more. They have more issues. And so like, I don't ask for any help. And I just think if you are in either one of those situations, I would love to offer some encouragement. First of all, there's nothing to be embarrassed about. We all have different challenges. Sometimes we have other expenses and we are making some really tough choices. And that's something that we all need to be supportive of together as a community. And if you feel like you need help, but you feel like you shouldn't ask for help because someone else might need help more, just know that there are unfortunately a lot of people that do need help. And as a community, we're going to find a way. We're going to do what we can to refer to organizations that can help. And it's not an issue for you to also need help, right? So please do ask if that's something that's coming up for you. Next slide. This is kind of our closing message here. Be your own advocate with this whole insurance selection, navigation, diabetes journey. You are your own best resource in getting what you need as a person living with diabetes. Like Dr. An said, many times your physician may not live with diabetes. They know a lot about diabetes, but they don't know what it's like to be you and live with diabetes. So if you need help, ask for it. That's the only way that anyone can know what it is that you need and can even have an opportunity to help navigate you towards what it is that you're looking for. And certainly here at the Mary and Dick Allen Diabetes Center, we want to do as much as we can to help you be your own advocate and help be an advocate for our patients and community. Next slide. We would love to welcome you to any of our community programs. We have the Herbert Family Program for Young Adults, First Fridays events for ages 18 to 30s. Our next one is coming up in December. We have our Type 1 virtual support group coming up November 17th, a special edition featuring Dr. Mark Heyman, the diabetes psychologist. And then we will also meet again in December. We have a diabetes and pregnancy virtual support group coming up in December as well. If you have any questions, please reach out to us. Our phone number and our email is here on the slide. And thank you so much for joining us. I know we shared a lot of information. Could potentially be a little overwhelming, but I'd like to open up the rest of our time to questions. If anyone's been sitting
So
on.
Samantha, there is a question on biosimilars, and I may be the one to
Okay.
answer.
Yeah.
So the question is, are biosimilars being covered as generics and basically the same? So biosimilars, for those of you that are not familiar, is very similar to generics. It's basically like, for example, Lantus. Many people know that that's insulin glargine. That's the generic name for insulin or for Lantus. And there's a company called Semglee and Basaglar. These are called biosimilar insulins, which are basically, it's the same glargine molecule. So it's basically a generic, but they're not called generics. They're called biosimilars. So in my experience, they tend to work the same. How would I phrase it? I would say if the cost to you is a big difference, like if it's definitely cheaper to switch to Basaglar, then I would definitely give it a try because for all intents and purposes, just like a generic, it should be the same. And then if you have a bad reaction or if you really don't feel like it's working the same, then we can try the prior auth again. So I would say biosimilars pretty much you can kind of treat them almost identically to generics. But unfortunately, the cost is not always in the generic tier. So this is where everything is so tricky. Like for example, Basaglar might be preferred because it's a generic, because it's a biosimilar, but it doesn't mean Basaglar is always going to be cheaper. Like Tresiba might still be cheaper than Basaglar because the Tresiba is the preferred basal insulin. So you can't just assume that Basaglar, because it's a biosimilar, is always going to be the cheapest long-acting insulin, which is very frustrating again. There's a question on where are we located? Samantha, do you want to answer that?
For sure. We are located in Orange County, California. The Mary and Dick Allen Diabetes Center has 2 locations. One is in Newport Beach, California. The other is in Irvine, California. So please give us a call if you'd like to come make an appointment with one of our diabetes care specialists. We also have virtual appointment options, telehealth available as well. So if you'd like to see one of our diabetes educators, clinicians, anyone across the board. That is an option, even if you are not just right around the corner from us.
One caveat to that is
Yes.
for medical services like dietitian services or seeing a physician, out of state virtual care is because of medical licensing issues, we can't, I can't do that easily. So, but if you're in like San Francisco and you want a virtual visit with our dietitian, that's fine. But if you're in Washington, because it would be crossing state lines, that would not be possible. But our free programs, just like this one you're watching here, is available to everybody because that doesn't go through insurance.
Very important to point that out. Thank you, Dr. On. If anyone has any other questions, we'd love to answer them before we wrap up. This is a topic that has a lot of different nuances to it, and every year little things change. But even with everything that stays the same, there's still a lot to learn, no matter how long you've been doing life with diabetes.
Yeah, it's definitely crazy. And I've been a doctor for, 10, 15 years. And I'm still learning craziness about insurance. So I can't expect, I still feel like I only know 70% of health insurance. It's such a nightmare to fully grasp, but unfortunately it's so important as I had stated previously. So yeah, it's a learning process for sure.
Absolutely. Just staying open to learning, asking questions like we talked about, advocating for yourself, communicating with your care team, communicating with other people in the diabetes community. Um, these are all different ways that you can continue to learn. And we are so appreciative of everyone who came out to listen to this and join us live. And of course, if you're watching this in the replay, thank you for seeking us out to help support you in this journey. This is something that really requires the village. So thank you for being a part of ours.
Thank you.